Okay, so
You're right.
I know you do all sorts of stuff, but
Hmm.
I really want to talk about facelifts because it's
Okay,
all
sounds
I
good.
think about right now.
Oh,
Hey, baby, it's time for the NIKKI ALPERT Podcast. Come on, pull up a chair. We gonna have some fun.
Dr. E, welcome to my virtual chair.
hello.
Hi, it is so nice to see you, and I'm so grateful for your time.
Well, thanks for having me, Nikki.
Absolutely. So here's the deal. I am now at the age where all day, if I pass a mirror, I can't believe what I see, and I do this. And I'm sure every woman who comes to your chair tells you the same thing. Am I right?
Yes. Depending on how old they are, right? Patients go from teenagers to,
Oh,
late octogenarian, right? So
okay.
everybody has different needs, but yes, a certain demographic, certain age group, that's what they do the most.
Okay,
You're
so
right.
I know you do all sorts of stuff, but
Hmm.
I really want to talk about facelifts because it's
Okay,
all
sounds
I
good.
think about right
Oh,
now.
I don't think you need it, Nikki.
Well, listen, you're seeing me with really good lighting on because I didn't have the nerve to record this without it on. But if I were to walk into your office today, you'd be like, wait, are you Nikki? You do not look the
Right?
same.
Well, you know
So,
what? Funny thing is, a lot of people say that. Why can I look like this, celebrities on magazines? Well, take your makeup artist, take up the lighting, and, have the Photoshops, and
that's
you look
right.
just like them,
That's
right?
right, because they don't
Yep.
look like that either.
No,
100% true.
never, never.
I mean, women sit in my chair all the time and they're always doing this. And I remember my mother doing it. And I mean, it just seems to be like a rite of passage. You get to a certain age and what's happening to me where I'm losing fat in my face, but not in my body. I don't understand that. And I'm losing fat in like, or everything's settling here. Like I used to be fuller here and now it's all settling to here. So let's pretend that I'm in your office and
Okay,
I'm coming in for a consultation for you to lift my face. So,
okay.
okay, so my first question is, if I have Botox and filler and all that, do I have to wait for that stuff to go away, or can you see past that when you're figuring out what to do?
Absolutely, you can see it through, right? I
Okay,
mean, I guess that's where the learning curve as a plastic surgeon will figure that out, right?
right,
Only thing is that patients have to let us know how much fillers that they have. Botox doesn't really make that much difference
right.
because it is actually controlling the expressional lines. However, the fullness really does make difference. So, for instance, when patient comes in and say, "God, I want to have surgery, but I want to lose 20, 30 pounds before I do it." Of course, you want to lose the weight and
Because the
have
skin's
less
gonna
fat.
sag
Yeah,
after you
exactly,
do.
right.
Yeah,
So for same reason, if somebody has a lot of fillers in their face, it's really hard to gauge how much of that is their own fullness or something that
right.
will go away after surgery.
Which would
So that's
suck.
right, exactly, right. So some people just know that they do have to keep doing the fillers anyway, and that's exactly what we tell people. After surgery, you still have to maintain. Only thing the surgery can do is really take up excess skin that's thinning out and there's a little looseness and laxity. We can pull it up and we can take it up. We cannot restore the volume that you've lost, right?
But you do that with
So
fat grafting, don't you
right, right, right,
sometimes?
right. There are sometimes that you can do that with the fat grafts and repositioning the fat and all that. But at the same time, that's a finite amount of your own volume.
Right.
So as time goes by, you're gonna have to replenish that anyway,
Does
right?
fat
So
last longer than fillers, than Juvederm and all that stuff? Your
well,
own
it
fat?
depends. Yeah, that's a good question. About 20, 30 years ago, fat injection was really popular, right? Because the only thing that was available back then was collagen. Like you have to do
Oh.
skin test. And the joke about collagen is that by the time you get to the parking lot, it goes away, right? So that was a joke. Now, so at that time, we did a lot of fat graft, right? And one of the limitations about fat graft is that not everything that we inject will stay 100%.
Why?
Meaning that, well, let's say we take a little bit of fat out from your belly, right?
Okay.
Well, during the process, some of the fat are already damaged through the process, but there's no way of knowing how much of that is actually viable and how much is already damaged.
Interesting.
But there's no way of knowing, so we drain the fluid and we concentrate the fat in a syringe and we inject into the area. Now, there are certain limitations as to how much of that was injected will survive also, because number one, the percentage is only less percentage is viable, right? Now, out of that, we really have to depend on patient's body, the recipient area, to establish new blood vessels.
Okay, which
So
takes
that-
time too. I mean, you put it
Oh
in
yeah,
there. And
absolutely. So if that doesn't survive, it's just like doing a heart, heart transplant. If you don't connect the blood vessels to the new heart, that heart's gonna die, right?
Yeah.
So fat is the same thing. If you don't establish new blood vessels into the fat cells, no matter how healthy and no matter how viable it was when it came out of your belly, it's not gonna survive. So there is no perfect science as to I in my hand 30%, 40%, 50% will survive. There's no way of knowing because every patient is different. Right?
Okay, so after we do my face,
All right.
we will need to continue with Juvederm and Botox and all of that.
Absolutely.
Okay,
That's part of the maintenance.
And it's funny because, when my mom and my grandmother got their faces done, I remember my grandmother started later in life. So, she went from looking really old to looking a little stretched. And it seems that now women my age, I'm 55, so I might be on the older spectrum of when people are starting, but even women 44, because I've been watching facelifts for the last 2 weeks since we first talked.
Okay.
Online all day long. It's a little crazy, and I like it. But it seems like women are doing it earlier to prevent the aging as opposed to trying to turn back time completely. And I would guess that makes your job a lot easier. I don't mean easy, but like a lot less to do, and people don't look so weird after because you're not trying to erase so much time.
Right. Well, it's a sensitive subject, right? When patient comes in, they could be anywhere between late 30s to early 90s, right?
Oh, God.
Everybody has a different needs. Now, I always tell patients, when somebody comes in and say, this is what bothers me. And if I can meet their expectation for what they're trying to achieve, then it is really nobody else's business but theirs and mine. Mm-hmm. My goal is to meet their expectation, yet also give them enough information so that they can actually make informed decision, right? So it really, there is no wrong time when surgeon can meet their expectation, which means it's not wrong to do it now, or it's not wrong to do it 10 years from now,
right?
Because you're already there.
There meaning someplace that doesn't make you happy.
Right, exactly.
Okay.
No, well, not only that, it doesn't matter when you do it.
Right.
If you already have the needs to do something and I can meet your expectation, then from this time on, it's all good time.
Right.
So I always tell people that, hey, listen, there's no right or wrong time at this point. You can wait for another 5 years, or you can do it tomorrow. You will get your, desired goal by having a surgery, right? Mm-hmm. Now, there are some people, like you said, if you do too many times, number one, you start getting your hairline distorted. Number two, your skin gets a little pulled, right? Yeah. Although you can prevent that with that's the learning curve and also nuance of certain technique is that you can prevent that. But at some point when skin gets so thin, it doesn't happen to everybody. It usually happens to people with a very delicate skin, very thin skin, and also very narrow face. When you pull, there's nothing to hang on to, so they tend to look a little stretched. Right. So yeah, there are a lot of things that we do to prevent it from happening, but
it can't happen.
Right.
Okay, so when I think about coming in, and I know that you guys take all those angle pictures.
Right.
And I've seen them all, and I get emotional looking at other people's things. So I get the feeling that I know what I look like, but if you took pictures of every of my worst angle and showed me where this was happening and this was first of all, I think I would break down in your chair, which I'm guessing happens a lot. Does it happen? Do people cry in your chair?
Not really.
Okay.
They do have pretty. Yeah, they do pretty. They have a pretty good idea. Of self. Awareness about.
Oh, I know it. I just don't want to keep seeing it.
only thing, the funniest thing is the only thing when they come in and they are complaining about loose skin under their neck, right?
Yeah.
So I give them a handheld mirror and they'll hold it like this, but they always try to look up the loose skin, but by the time they do that, it's gone.
It's gone.
I'm like, you don't have it.
No, when I'm
so
outside.
It's always a joke, right?
Yeah, when I'm outside and somebody calls me and the sun hits my phone and all of a sudden, I see that I actually have a line of wrinkles. Who is that?
right?
You know, my grandmother, can I tell you, my grandmother used to not do her makeup in the mirror. And one day I said to her, Granny, how are you doing your makeup? She said, Nikki, when I look in the mirror, I don't know who that old bitch is staring back at me. I can't do it anymore.
That's funny. So I'm going to tell you a funny story.
Please.
So I think it probably happened about 3 or 4 times. I'll do a facelift on a patient. And it's not, like maybe about 3-4 months later, I get pictures of a patient complaining. And she goes, when I go like this, I got a little skin right there, right? I'm like, you're right, Susan. If I did a surgery with your neck bent like this, you probably wouldn't have it, but you probably wouldn't go like this.
But if you put your face up straight.
Right, exactly, right. So we can only make your face at a resting stage.
Yeah.
And thereafter, no matter what we do, if you kind of bend in a certain way, your skin's not going to be a rubber band. Yeah, it's a skin. The true goal for me is that you want to make them look the best for their age.
Yeah.
Not 30 years younger, not 20 years younger. The one thing about facelift is kind of tricky, right? Because when you're doing rhinoplasty, let's say people had a huge nasal hump and tip is droopy and they never like their nose. So they don't have any idea what it is going to look like. So they have no preconceived idea
of what they used to look like with a better nose.
Right.
Yeah.
But face, they have an evidence, right?
Yeah.
They know what they look like 20, 30, 40, 50.
Yeah.
And they want to look back to I wanna look like 30 years old picture. I'm like, right? So there is a little bit of that meeting the expectation with the patients.
Right.
And that's I guess really the fine arts of a plastic surgeon.
Right. And so it used to be that people seemed to be pulled this way. But in all the stuff I've been watching, it seems that people specialize now more in doing more of a vertical lift. Is that something that just happened?
You know what? No. That's been always the same way. You have to pull it multi-directional on the face. So let's say everybody's different too. If somebody has a really lot of loose skin right under the chin, then you do have to bring it up this way, right? I mean, that's the only way that you can do that from. It's almost like a U-shaped sling.
Okay.
But then if you have loose skin in front of your neck, that has to go back behind your neck towards the back of the ear.
So that's when people get the scars in the back of their hairline under their occipital bone?
Right.
Okay.
Exactly. So it really depends on what you're doing and what your goal is.
Yeah.
So incision lines and direction of pull, I get patients coming in, have done a lot of research, and they say, hey, I want this type of approach, right? I mean, there's 3 different type of approaches to facelift, most commonly used. So they do all the research and they think that somehow they convince themselves that is the best approach by reading so many things. But bottom line is, it really doesn't matter. Yeah. It really has to do with what we find out under your skin and what makes you look the best. So, don't get so hung up on one technique.
Right.
My goal as a surgeon is that, be ready to do any kind of approach proficiently and effectively so that it will kind of give you the patience. For instance, I mean, if somebody comes in and I go, God, I want this type of facelift, but then I go in there, I go, God, I got to go deep plane because your skin's so thin.
So what's the difference between deep plane? I've read about deep plane, that there's deep plane, and then what is deep plane? Under the muscle?
Deep? Yeah, well, in the face, there's no muscle. It's called SMOS, right?
Oh,
and
SMOS,
yeah, it's
right.
a SMOS. So you go deeper towards the SMOS. And the other way to do it is you go more extending the skin only and do limited amount of that little layer. Now on the neck, it's all muscle, right? So it all depends on, you want to go to a surgeon who can actually approach it from both angles,
right?
Because everybody could be different. You can't just promise somebody, I'm going to go deep plane. But then, for instance, let's say I have somebody coming in at 40 years old, she needs minimum work. You don't want to do something that will prevent her or make the second surgeon who's going in 20 years from now. You don't want to, I always have the mindset that I want to be, let's say I'm operating this person again 10, 15, 20 years later, right? I want to preserve as much as possible, yet get the most out of the current situation. And that really determines how I'm going to approach the facelift.
So when you say preserve as much as possible, you mean leave as much
normal anatomy.
Okay. Okay.
Right.
So don't cut stuff out that you are going to need later to be able to cut out or whatever.
Exactly. But you still want to get the maximum effect, right? I mean,
Okay,
that's
so
going to look
yeah,
natural.
so I've done the research and I can tell you what I want because I'm just like everybody else. I WebMD'd my facelift.
Okay.
So I want, okay, so I want a lower facelift with fat grafting and laser resurfacing. Is that something that happens a lot? Like, do people do all that stuff?
Absolutely.
And am I talking like $50,000? I mean, I know you don't talk price, so but it could be, right?
It all really depends on surgeons and I mean,
on the rent.
Exactly. You can go to Beverly Hills and pay 3 times more than that, right?
Right.
So it all depends. The price is really something that doctor really has to do with his comfort level.
Right.
Yeah. And
we don't need to talk about price. I'm just throwing that out there.
You know what? No. Trust me, there are some guys who are or female surgeons charging just exorbitant amount of money. Yeah. And I just don't get that. But I mean, there are people who actually pay that kind of money because thinking that they are going to do a better job.
That is true.
There's a market for everybody.
Yeah. I guess you're right. You're right. Okay. So if I came to you and I said, that's what I want. So what would you say to me? Obviously, you would take my pictures and then you would talk about what would be the next stage to talk about. Like, I tell you what I want, what bothers me. And then what do you ask me? What do you do to me then?
So let's say you came to my office and we talked about exactly what we're going to do, right? Then we'll actually take you to my surgical coordinator and she will discuss about the price.
Okay.
And then we'll actually have you come back for pre-op. And during that time, what we do is we go over all the risk factors, post-op care, and all the medications you're going to be receiving. And that's basically, by the time you get there, you would have medical clearance from your internist and blood workups. And
can I do it being a diabetic?
Oh, absolutely. As long as the glucose level is well controlled. I mean, that's not a problem at all. Yeah, that's basically what happens. And then we'll take pictures of your face. Usually, most people do walk around with the makeup on, but I mean, it's better if you don't have any makeup on. Now, the funniest thing about the before and after shots for a lot of plastic surgeons is that they got
the makeup after,
and then all the makeup and hair, right? So you want to be consistent.
Come in with our hair up and no makeup on, and then we went to Nordstrom and got our makeup done and our hair done professionally for our afters.
Remember that extreme makeover? And my wife used to say, only thing that makes really difference is a hair and their makeup.
Yeah, absolutely. By the way, your wife, can I tell you, if I was young, I would want to marry a plastic surgeon now.
Oh, I don't know.
It never occurred to me when I was younger to think you should marry a plastic surgeon so that when you get older, you're golden. I just never thought about that. But now I would go meet every plastic surgeon in the city when I was young and hot and flirt with one and fall in love with one, and you would be my husband.
So this is what my wife always complains about. She goes, you never look at my face as you're looking at your patients. I go, honey, I deal with it all day long. Last thing I want to do is talk about other face at home.
It's a good thing you're not a gynecologist.
Right? You're right. Oh, well, let's not go there.
I think I just did.
Okay, off limit.
Okay, so we're going to do my face. So do you go over like where you cut and what you do? And I know all of that?
Yes. So we're going to go over. I mean, that actually happens during the first consultation.
So talk to me.
About surgery. Okay. So incisions usually for the facelift, depending on how much of a fullness or loose skin under the chin that you have.
You have to go here sometimes.
So we make a small incision right under your chin, right? Yeah, exactly. So when you put your chin down, there's always a little crease. So we make about an inch incision right there. We take out all the fullness between your skin and the muscle. And then we actually, what I do is some doctors actually go in there and do a liposuction. I don't like doing that because liposuction itself is blinded procedure.
It's bumpy too.
So you can actually bruise patients a lot more by doing. Yeah, exactly. Because it's not even, extraction of the fat.
Because you're doing this.
So I actually lift up the skin. Yeah, right, exactly. So you take out the fat and then you actually examine the muscle. So before surgery, during consultation, I always ask patients to clench their teeth and show me the neckline like Incredible Hulk, right? So by looking at that, I have a pretty good idea where their muscle bands are. So you go in there and you examine the fat. Take the fat out, examine the muscle. If it's like in my, in medical terminology, if it's well decussated, like crossed over in the middle, sometimes it's better not to touch it. If it's loose or separated, then you actually tighten it up right there, the muscle.
Is it supposed to be crossed over? Is that a healthy
No,
muscle tissue?
it's an anatomical variation. They both are normal.
Okay.
Some people are born with that, some people aren't. Okay. So some people actually have too much fat under the muscle, not under the skin, between the muscle and the skin, but some people actually have under the muscle. Those are really hard to get out. For instance, I just had a patient who flew in from Hawaii and did a surgery on him. I mean, when I opened it up, I mean, it was all under the muscle. So those
How do you get it out?
You can't, there's a limitation as much. I mean, you can't get it out all 100% on that one, because there are important structures that you don't want to violate, right? So you do best as you can. You take the muscle, you take submuscular fat, and then you close the muscle. Now, once that's done, the incision goes around the face, usually behind the temple, behind the hairline of the temporal hair, go towards the ear, and then it goes around the ear and behind this thing called tragus. Okay. Now, for men, we actually go in front of that, because if we go like same as a female incision, that tragus, that little bone cartilage, gets covered by the hair-bearing skin, so they ended up having shaving that every day.
Because you pull the hair, because you pull the face back so much, their beard goes into their ear.
Exactly. So for men, we actually make this incision right in front of the ear, and it works beautifully. For women, we actually go behind it. Okay.
When you cut into here, what happens to the hair follicles? Do they die?
You don't. No. The reason that we make an incision up there is every removal of, let's say you're removing this much of skin, right?
Right.
Well, you can't really close like this without tapering the incision line really long and thin towards the end. That's why we're making an incision up to here. So when we close it, it comes out really nicely. So
do you cut off do you actually cut off some scalp?
Right, exactly.
Okay, so you're removing scalp, not just facial skin.
Right.
More scalp actually than facial skin, it sounds like.
Right. And facelift is not so much as how much skin that you're taking out, it's how much of displacement that you get. So a lot of times the patient has a mole right here before surgery. After surgery, the mole's gonna go up higher. So it's not so much of skin that you're taking out, it's a displacement of that skin in certain direction that will get the best result. Right.
I see.
So your hairline's gonna start moving back up, Yeah.
Okay.
So the incision goes behind the ear into the crease and then goes into the hairline again. Okay.
Back there.
Now, the reason that we make a long incision is exactly not so much of that we are working on all that area, but also enable us to close it nicely so you don't get what they call dog ear. When the incisions
like
are closed like this, and then it looks like a little shepherd's ear, or dog ear.
Yeah.
So it kind of bumps out at the end of incision. So that's why we make a longer incision than the area that we are working on.
I see.
So for instance, when you're taking a mole from the face,
right.
Let's say you have a round mole, the incision is about 3 times long as the diameter, because we can't just hold out the circle and being able to close it.
Right. You get like a weird tuck hole.
Right. Exactly.
Okay.
So that's why the incisions are a lot longer, and most patients, they're actually surprised. Some patients go, "Wow, I don't want that, incision." Yeah. Like, well, there is nothing we can do. If you're gonna correct all that, that's the incision that you have to have. It's better to be upfront and let people aware of what they're going through than, telling people, "Oh yeah, your incision is gonna be limited." I've had patients come in and go, "Oh yeah, this doctor told me the incision is gonna be this big." I'm like, go talk to them again. Yeah. Because it really...
They tell you what you want to hear and they'll deal with it later.
Right, exactly. And that's like the wrong way to approach it.
Absolutely.
Yeah.
And the incisions, how long until those look like they're really gonna look?
About a year.
About a year.
Now, around the ears, non-hair-bearing area, the skin area, heals pretty fast. And you can easily cover it with makeup within about a month. Within a few weeks.
Yeah, I've heard people can be like red carpet ready in 2 weeks.
Oh, yeah. The scalp, however, always gets a little thicker. And then it remodels itself and flattens out.
But the hair doesn't grow back on that, right? The hair gets damaged. Follicle.
It depends it really depends. Yes. Whenever we make an incision, there are some hair follicles that gets damaged,
right?
But it also has to do with how much tension we are putting in the incision line as well. So if I want to minimize hair follicular trauma, what we do is we have to do a little less aggressive and have the scalp come together without much tension. Then your incision line is really paper thin.
I
Now,
see.
if somebody says, I want you to pull as much as possible, and we do have to put a lot of tension on it, then what happens is that your body, as it heals, when there's a lot of like separating force, your body's reaction is let's go in there, make it stronger.
Right.
So you get like this lump of like scar tissue right
tissue.
along there.
Right.
Now, what happens is that eventually it flattens out as your body feels less of a tension.
Mm-hmm.
So when that happens, it flattens out, but then you're right. At that point, the lump of tissue becomes non-hair bearing scar.
I see.
So about a year later, when it flattens out, some people, we just go in there, we just cut out the scar alone, and then we reclose it without intention. So that may work out at that point.
If that's an issue.
Right, exactly.
Because doing hair, I see scars on people's heads all the time that just have no hair on them. So I've noticed this. All right, so if I do all of this, and then, so you go in, how long does this take under, and by the way, not everybody goes under anymore.
Right.
Tell me about that.
My criteria for going under local, which means you don't have to go to sleep for it.
Yeah, and you can talk to me during it.
Well, number one, if the patient's very anxious.
Oh no, put him to sleep.
Nervous. Put them to sleep. It's not worth the
your aggravation.
She's not going to be happy, and it takes a constant away from my focus.
Your job,
right?
Yeah.
The other thing is also I always ask them, how often do you have to go to the bathroom? Because bottom line, you have to be on table for at least 3.5 hours if we do everything. Now, there are some patients that we can get away a little faster, but you got to assume that they're going to be on the table for about 3.5 hours. Now, if they have to go to the bathroom, it becomes a huge problem because they can't, right? So that's another limitation.
So when you're under, you don't have to go to the bathroom, or you just pee yourself and nobody cares?
No. Usually they don't have to.
Okay.
Your bladder is relaxed so that you don't have to. I mean, as soon as you wake up, you may have to go, but you don't, right?
Okay.
And in long cases, we actually put Foley catheter, so we actually evacuate the urine anyway. But those are like 5, 6, 7 hour surgery, right?
Oh,
so
God, okay.
Just the face alone.
So someone like me, we're not talking about 5 or 7 hours, and I don't have a
That's
bladder problem.
3.5 hours, so we don't do that.
Right. Plus, I wouldn't drink water right before I got there either, or coffee.
Right, exactly. You can't, if you have anesthesia, you can't eat or drink anything,
that's right.
Midnight prior, so you're pretty dehydrated.
That's right.
Yeah. And during the time, we also, anesthesiologists will say, you know what, I'm going to just kind of give her a little bit of fluid during the surgery, but when she wakes up, I'm going to give her plenty of fluid. So at that point, they can actually urinate, right? So anyway, number one, bladder size. Okay. Number two, if they're very anxious. Number three, if they have a back problem, because operating table is pretty hard and firm.
So they're uncomfortable.
For you to lay down there for about 3.5 hours, when they start fidgeting because the back hurts, it also takes concentration,
So is it easier for you to put people to sleep? Is that easier for you? You like it better?
It's easier. It's a lot easier. Absolutely.
And are you talking about intubated?
Intubated or what they call laryngeal mask. Now, that's a good question. I'm going to tell you, a lot of times people think that being intubated is really dangerous, but that's the safest method of general anesthesia.
That sounds terrifying to me. You're right.
But it is the most secure way to establish your airway. So when you I don't know if you ever took a CPR class, but the letters is A, B, C of CPR, right? Mm-hmm. A stands for airway. Without the airway, it doesn't matter if you get B and C.
Right.
Right. So in anesthesia perspective is that you secure the airway first. So by intubating, you're controlling their airway. Number two, you don't have any reflux problem or secretions going into your lungs. So you prevent what we call the aspiration pneumonia, which is really dangerous thing.
How do you see the mouth and everything? If they've got a tube in their mouth, how do you make it so that everything...
Oh, no. There are different types of tubes that it's very flexible. So it kind of sticks out. So it doesn't really distort your mouth or anything like that. And also there's another...
You wake up like this.
Yeah, right. There's another airway control called LMA, which is not an intubation, but then it's like a little mask that sits on your vocal cords. So it actually controls the air in and out, but it's not really 100% prevention of the aspiration. However, sometimes we used to do it that way too, but I really think that by putting a mask in there, it extends your volume right there. So when you actually pull, it fights against you.
I
So
see.
that's my thought process on that. And
All
then
right.
lastly, you can do what they call MAC, which is like everybody knows approachable. And they
I
put a
love that
little
now.
nasal cannula, give some air, patient breathe on their own. That's great, but sometimes patients do wake up in the middle of it. They don't remember it, but they move. They don't remember a thing, but they move.
That could be a
Sometimes,
problem.
right. And sometimes they could aspirate from gastric reflux, and it's not the best way to do it. But, some patients who are so apprehensive about anesthesia, general anesthesia, but also afraid of doing it on the local, we resort to that. But that's really rare.
Okay.
Patients usually follow my recommendation.
Yeah.
I mean, when I explain it the way that I just did,
Yeah, you don't want to aspirate.
safest to do it is really intubate. I mean, they usually have no problem with that.
Yeah. I have never been intubated, but and it sounds terrifying indeed. But so does aspirating and all that other stuff that could happen. I just want to go to sleep and wake up beautiful. So
Right.
I know I don't
Go
wake
ahead.
up beautiful because it's a couple of days before you look anything like normal after.
That's why most aftercare facilities don't have mirror in the room.
I want to do that too. I don't think I want to come home to my husband and have him be terrified for a week.
Right. But you know what, though? If you're just doing the facelift surgery,
Yeah.
you actually look pretty normal.
I don't
Surgery
think I
heals
thought about
fast.
Okay. And how many
Yeah.
stitches are you talking about at the end of a facelift? Have you ever counted?
I'm sorry, I never counted.
So just
I
a
have
lot.
patients who counted as I was taking it out. I have patients who counted it. I think somewhere around 60 staples and about 60 sutures. And that's not counting the ones that's buried on the skin either.
That's right. The ones that just, do
Right.
those dissolve underneath the skin?
Yes.
Okay.
Yes, they do.
And yeah, that's a lot. The ones that you do under there. Jeez. Wait, I just lost my train of thought. We were talking about the stitches and the staples. So staples, why staples?
Okay. There are some doctors who use sutures for everything. I'm only going by my own experience. So staples is like paper staples, right?
Right.
It's open at the bottom, right? So what happens is that when it goes in, it still has a little bit of blood flow to the skin that's trapping it. So it's really important in the scalp. You don't want to cut off the blood supply to your hair follicles. So in the scalp, I like to use staples.
That
And
makes sense.
number two, it's actually a little stronger than sutures. So it holds a thicker skin with a lot more tension, much better than sutures. Okay, so sutures in around the ear, where there's only skin to skin.
Right.
If it's a scalp to scalp, it should be staples.
Okay.
Right. I also don't like to use absorbable sutures. Some people actually use absorbable sutures behind the ear where there's a little crease, thinking that it's really hard to get those sutures out. I really think that's a lazy way to do it. Any absorbable sutures cause a little bit more of an inflammation, so it kind of makes your scar a little thicker at the end. So even if I have to leave the sutures a little longer, I think it's a better way to do it with non-absorbable sutures. Yeah.
And so the staples here, I swear to God, the idea of somebody putting a staple in by my temple seems like that could just kill you if somebody did it wrong.
No. Nikki, what I do is only skin deep. And I always have to remind patients, unfortunately that's your face, you can't hide, right? But
yeah.
it is a skin dip. It's very safe surgery.
Watching it and learning that you guys put so much lidocaine in there, it's amazing how little blood there is when you're peeling the skin off of somebody's face. I mean, I expected it to be a bloody mess, and it's not, which makes it much more easy to watch,
Right.
But it was shocking. Like I didn't know that lidocaine stopped bleeding, and so I didn't know. And when they were doing
it's not lidocaine. It's not lidocaine. Some lidocaine is mixed with adrenaline, what we call epinephrine.
Okay.
So epinephrine is what we call the vasoconstrictor. It clamps down on blood vessels.
I see.
Epinephrine, because it constricts the blood vessels, we have less blood loss.
Yeah. I mean, honestly, it's not like you're cutting people's faces open and the people aren't dripping with blood. It's crazy.
Right. So here's my follow-up statement for that. See, like a lot of people think that doctors are smart and all that, but you know who the real genius behind this is? People who recognize the properties of certain chemicals that came from plants, right, or animals. Understanding that when you use this, you can numb the patient so we can cut. When you use this, we can cut without much blood loss. The scientist, right, behind it, who enables us to do those surgeries,
to do your work.
They are the true genius in the world. And I mean, to this day, I just like,
thank
wow,
them every day.
I appreciate them. Yeah. Oh, yeah, absolutely. Otherwise, we wouldn't exist.
And have you seen great changes in that in your 24 years of practice?
Well, in medicine-wise, not really.
Okay.
There are some changes that we do to control the pain a little better. I think what really changes, really every surgeon refines their technique. So I think that's the beauty of like having experience behind your, career.
Your doctor,
yeah, too.
Right.
But also being a doctor, you're a student for the rest of your life. So you have to
Right.
constantly learn, adapt, and to improve your technique. So yeah, that's what it is. And did a lot of things change? Yeah, there once in a great while there are some changes, but not a lot. I think one thing that changed a lot in plastic surgery is really what we do non-surgically.
Right.
Injectables,
Fillers and Botox and all that stuff.
Right. Before 25 years ago, when there was only collagen, before Botox came out, before hyaluronic acid came out, really everybody was getting cut. Everybody was getting lifted.
Yeah, absolutely.
But now we can buy so much time doing all this like non-aggressive stuff.
Right.
That it really changed the direction or how we approach.
But like you said, fillers and Botox cannot do what a facelift does.
Oh no,
And
there's a limitation, of course. When you have excess skin, it's almost like alteration. You got a long pants or a wide waist. You got to take it up. That's surgery.
yeah.
Okay. You're going to get there with sooner or later because skin's going to, loosen up. The laser that you're thinking about is more like ironing. You got a perfectly fit shirt, but it's wrinkled. You got to go in there and iron it out. In terms of you're 55, you're looking like this right now. If you do surgery, you'll probably require another one in about 15 years.
Okay.
Now, that said, what I noticed that in people is that your tolerance level goes down, right? Meaning that 5 years from now, you say, right after surgery, you know what it looks like. You're feeling great. And although you may not have gotten back everything that you started with, 5 years from now, when you start seeing that little bit of change, you know what surgery could do. Right. So your tolerance level goes down so little in some people.
For the changes.
They'll just go, yeah, I just want this. Can you just do this? Yeah. Well, it's my job to say, you know what, take it easy there.
Good.
It's too early. You should wait. Yeah. So there's got to be open communication with the patients. But there are some people who would actually, if they could, they would do it every year.
Well, and we see the evidence of that with the people who their faces look like aliens because every time they put filler in, then they notice a line here. And, when your face moves, you might create a different dimple or a different line, and then they feel that, and then they feel this, and all of a sudden they don't look anything like they ever did. Unlike what a facelift does, takes you back 10 years, but filler just makes every woman look like a Stepford wife. Right. Or like an alien that they all went up to Mars together and came back with this whole new shaped face. It's the weirdest looking thing ever, I think.
Right. And they all go to the same doctor, right?
Because other doctors kick them out.
There's a circle of friends who always look the same.
It's bizarre.
Right? So my patients will never find those doctors, and that doctor's patients will never find you. Because we kind of circle around and never overlap. Right?
Yeah. So people do what they do and they get known for it.
Right. And I'll tell you a funny story. But I had a patient one time, came with pages of things that she's done in her life, cosmetic surgery, and wrote down, didn't like this, didn't like that. She asked me specifically, can you do this? Can you use this product? Can you do it this way? And I'm looking at her, I'm like, oh my God. So I told her no. And I told her that I would actually undo everything that she's done. Mm-hmm. If I do what you're asking me to do, I'm going to end up on that last page. And I refuse to do that.
Good for you.
And she actually followed my recommendation.
Did you make her look a lot better?
I'm so happy that she looks so much more feminine and soft without looking harsh. You know, those people looking harsh. You know, in certain lights they may look good. You know, from far they may look good.
Yeah, but they look bumpy and thin-skinned.
Oh my God! Yeah. So we just deconstructed somebody, and I'm just so happy that she decided to go with my recommendation. Yeah. So it's I always say I'm doing psychology with a knife. Right?
But you are, because listen, the way we look so affects the way we feel. I mean, I know that when I wake up in the morning and I jump out of bed and I feel young and sprite, and then I walk into my bathroom where it's the worst lighting in the house and I'm like, who is that? And listen, 55 and healthy is the goal. Thank God I am this age. And so if I have to show some of it, I'm cool with it.
Nikki, I think 45 would be better for me at least. Right?
Agreed, which is why we're talking.
I'm telling you, I mean, 50, I feel it. Right?
Yeah, that's true. Listen, I do. By the way, in case you haven't noticed, I've been putting my knee up and putting my knee down because my knee hurts sitting here.
Right?
So
Exactly.
yeah, I do feel it, but still, I feel like I look older than I feel, even than my knee feels or whatever.
No, you don't. No,
well, that's because you're seeing me in
fantastic,
incredible
Nikki.
light. Thank you.
Yeah. Well.
I'm telling you, when I walk in there, you're not going to
Okay, sounds good.
Okay, so I come in a week later, I do the pre-op where we talk about all my meds and all of that stuff. I come in. Now, if I were to go to an aftercare facility, how long do you stay there?
I would recommend at least 2 days, minimum 2 days. The reason is it's like hotel. You check in at 4, you got to leave by certain times because they got to get ready for next patient coming in. Right? So usually I like to, because the time that you need somebody's help is really next full day. Right? It's not like you get up. I mean, by the time you get discharged, you go there about 4 o'clock, 10 o'clock, you got to leave. I mean, you want rest. You want somebody to take care of you at the time. So stay there for 2 days minimum. And that's what I would recommend. Now, some people stay there longer. It's up to them. Right.
And and that's just the luxury part of it. And I come to you the next day? The day after I come to you?
2 days later.
2 days later.
Every doctor's different. Every doctor's different. Also, there are some doctors who put drain, what we call JP tube in there. I don't.
Okay.
So when people put JP, you might have to go back next day to make sure that there's no drainage.
I saw them pulling that drain out from all the... Oh.
Right. Listen, I was taught that way. And that was the first thing that I modified in my technique is to stop doing that about 2 years out from my practice.
That's such good news.
Yeah.
The one person I came to your office with who had just had hers done, the bruising was so minimal. Like, I think I took her to you either the week after. Do you go 2 days and then a week later? How often?
Yeah, right. Exactly.
Okay.
2 days. Yeah, 2 and 7 days.
And when do you take the stitches out? At 7 days?
7 days. Yeah.
Okay, so that's when I came to the stitch removal meeting. What's the word?
Appointment.
I'm a little nervous about cutting my face open.
No, I want to see what's on the table. Do you have any drinks?
Okay, so I came with her to that appointment, and she was a little yellow. That was it, and not even very swollen. It's like 7 days later.
Yeah.
How do you explain that?
When you do surgery, it's different than getting bumped into the corner of the table and get bruised. So when you have a dissection, meaning that we lift up the skin, so there's a channel where all the bruising can migrate down. It doesn't get trapped into your skin.
Right.
So surgical bruising goes away a lot faster than if you just got a blunt trauma or bump into something.
I see. Okay.
Yeah. So that's why the surgical surgeries, facelift, really shouldn't cause that much bruising unless you're a bleeder. It's a whole different story.
Right. So if you're hemophiliac, don't get that done.
Well, we don't do surgery on hemophiliacs.
I would imagine not.
Right.
Wow. Okay, this is a lot to take in. So is everybody a nervous wreck when they leave the first time before they, do people just change their mind about it once they find out a lot of this? Often?
Not really. When patients are determined, they pretty much go through it. But making a decision, I always tell patients the hardest part is really time that you start thinking about doing it and getting onto the table. That's the hardest part.
Yeah.
Once you've gone through it, they'll just go, why didn't I do this earlier?
I hear that often. All right, so when I come to you, which will be as soon as I get my vaccines,
all right,
I'm going to want a facelift. We'll talk about touch laser things if you think you can do them someplace. And And so the injectables and the Botox, do you do that while I'm under or while I'm on the table?
No. We usually hold it off for a while. Let's say if I do a brow lift and I do Botox on the forehead, so during the healing, it doesn't move that much. So that's one exception. But if somebody's interested in doing like fillers and Botox and they want to do surgery, if it's within 3 months, I just tell them to hold off on it. It's just like there's no reason to do it. Because of swelling. You don't even know what you're doing at that point.
That makes total sense to me.
Right.
Yeah.
Only thing that I do sometimes during the surgery is a sculptura. It basically makes your own skin to get thicker. So it's not a filler, it's your own inflammation of your skin. So it deposits a lot of building blocks under your skin.
Meaning collagen?
Collagen or hyaluronic acid.
Okay.
Elastins, it's just like anything that makes your skin to be a little bit fuller. So those I do it sometimes in the area where I don't elevate the skin. So I do that. But fillers, you don't really need to do it because it gets metabolized really fast.
Right. So by the time you heal, it's gone.
Right, exactly.
Yeah.
And then, when it's swollen, right, you think that that's a filler. When the swelling goes away, you go, where did my filler go, right?
Right.
Well, it's still there, but to patient's eyes, it's gone.
Right, so you've got to separate all that so we don't get lost in all of that. All right, and how soon can I start to exercise again?
Well, I always tell patients, if you're just doing the facelift, one of the things that you don't want to do is extending a range of motion on your neck. So if you extend your neck this way or turn side to side, you're putting a lot of unnecessary tension in the suture lines. So it feels very uncomfortable. Number two, it gives you a lot of swelling, intermittent swelling, slows down the healing. And number three, it may actually separate or widen your scar, right? Not that physically separating the wound, but it may actually make you're talking about the scar bigger. Yeah, the wide scar. Yeah. So you want to really minimize range of motion, but you can actually walk.
Okay.
Quite soon, like within 5 to 7 days, you can do like really long, light walk. Right?
Okay.
Not fast, not strenuous, not hills or downhill, just like window shopping pace. You can do that fast. Yeah. If you're like into yoga, golf, or anything that moves a lot of neck, 6 weeks.
Okay. Well, that's not so bad though.
Yeah. So I always tell patients that, if you have to think about it and wondering if you need to ask me,
then you do.
then you don't.
No, I'm saying then you do have to ask because the answer is no.
No. Answer's no. Yeah. So don't do it.
All right. So it's a big break. It's a month and a half break from the exercise thing that
if you're really into exercise. I mean, most people if they just want to go for a walk, you can do that right away.
Okay. So I'll have to
within
work
a week
on
or
that.
so. Yeah.
All right. I am so excited to come see you when it's safe to do so for me because I don't feel safe anywhere yet. But as soon as I get my vaccines, I am coming to see you and then we'll have to just we'll see how much of this we can do on my podcast if you want to. I don't know. Maybe we'll just do the before and afters.
All right, sounds good.
I am thrilled. I am thrilled to do this. I am thrilled to know you and to know your work and to know that I can trust what you do because I've seen what you do. And to hear you talk silly and seriously and so approachable and so relaxed, it's a pleasure.
Oh, thank you, Nikki.
I thank you so much for your time, Dr. Yi, and I'm sure you've got faces to lift and boobs to fix.
No, boobs I don't do. I'm a facial plastic guy.
Yeah, that's good.
Okay, last note. I'm so glad that I do just facelift. I got 15-year-old daughter, and nowadays I go, God, what if I did that? What would they think, her friends? And I got an 11-year-old son. I'm like, so I'm kind of glad that I just kind of stuck with the facelift. I mean, the facial plastic.
I love that because your daughter would just think she should get her boobs done because that's what you do.
Right? Exactly.
Says your podcasting friend with the 34 AA chest. I never did that. I've never gone under the knife, but with you,
I'm not seeing anything below your neck or shoulders. So.
Listen, if I had big boobs, you could bet I'd be doing something to show.
Yeah, right.
But I can't wait to go from the office to your table and wake up feeling excited to see what you've done.
Same here. Great.
I'm looking so forward to it.
All right.
Thank
you.
Thank you so much.
Bye-bye, Nikki.
Bye.